Halo, welcome back to Udah Study Club by Fitriana Aulia. Jadi, aku akan membuat satu bagian baru dari channel YouTubeku yang berisi tentang membaca. Jadi, membaca jurnal, membaca guideline, dan lain-lain dalam bahasa Inggris. Nah, tujuannya supaya bisa makin melancarkan Inggrisku sama, ya mau nggak mau aku juga harus membaca gitu. Jadi, sekalian aja untuk di-sharing ke publik sama biar nanti kalau misalkan pas luang gitu sambil rebahan bisa sambil dengerin video ini lagi. Oke, jadi untuk yang pertama ini itu aku mau baca guideline asma dari GINA 2024. Ini yang paling baru. Chapter 1, Definition, Description, and Diagnosis of Asthma in Adults, Adolescents, and Children 6 until 11 years. Key points. What is asthma? Asthma is a heterogeneous disease usually characterized by chronic airway inflammation. It is defined by the history of respiratory symptoms such as wheeze, shortness of breath, chest tightness, and cough that vary over time and in intensity, together with variable expiratory airflow limitation. One or more symptoms, example criteria, cough, may predominate. Airflow limitation may later become persistent. Asthma is usually associated with airway hyperresponsiveness and airway inflammation, but these are not necessary or sufficient to make the diagnosis. Recognizable clusters of demographic and clinical characteristics are called clinical asthma phenotypes. In most instances, these do not correlate strongly with specific pathological process or treatment response. However, biomarkers reflecting pathophysiological process are useful in the assessment of difficult to treat asthma and treatment of severe asthma. How is asthma diagnosed? The diagnosis of asthma is based on the history of characteristic symptom patterns and evidence of variable expiratory airflow limitation. They should be documented from bronchodilatory feasibility testing or other tests. More than one test may be needed to confirm asthma or exclude alternative causes of respiratory symptoms. Many health professionals do not have access to spirometry. If so, peak expiratory flow should be used, rather than relying on symptoms alone. Test before treating wherever possible. Document the evidence for the diagnosis of asthma before starting inhaled corticosteroid-containing treatment, as it is often more difficult to confirm the diagnosis once asthma control has improved. Additional or alternative strategies may be needed to confirm the diagnosis of asthma in particular populations, including patients already on ICS-containing treatment, the elderly, patients presenting with cough as the only symptoms, including cough variant asthma, and patients in low resource setting. Definition of asthma. Asthma is a heterogeneous disease, usually characterized by chronic airway inflammation. It is defined by the history of respiratory symptoms such as wheeze, shortness of breath, chest tightness, and cough that vary over time and in intensity, together with variable expiratory airflow limitation. This definition was reached by consensus based on consideration of the characteristics that are typical of asthma before ICS-containing treatment is commenced, and that distinguish it from other respiratory conditions. However, airflow limitation may become persistent later in the course of the disease. Description of asthma. Asthma is a common chronic respiratory disease affecting 1 until 29% of the population in different countries. Asthma is characterized by variable symptoms of wheeze, shortness of breath, chest tightness, and or cough, and by variable expiratory airway limitation. Both symptoms and airflow limitation characteristically vary over time and in intensity. These variations are often triggered by factors such as exercise, allergen or irritant exposure, change in weather, or viral respiratory infection. Symptoms and airflow limitation may resolve spontaneously or in response to medication and may sometimes be absent for weeks or months at a time. On the other hand, patients can experience episodic flare-ups or exacerbations of asthma that may be life-threatening and carry a significant burden to patients and the community. The majority of asthma deaths occur in low and middle income countries. Asthma is usually associated with airway hyperresponsiveness to direct or indirect stimuli and with chronic airway inflammation. These features usually persist even when symptoms are absent or lung function is normal, but may normalize with treatment. Asthma phenotypes. Asthma is a heterogeneous disease with different underlying disease process. Recognizable clusters of demographic, clinical, and or pathophysiological characteristics are often called asthma phenotypes. In patients with more severe asthma, some phenotype-guided treatments are available. However, except in patients with severe asthma, no strong relationship has been found between specific pathological features and particular clinical patterns or treatment response. More research is needed to understand the clinical utility of phenotype classification in asthma. Many clinical phenotypes of asthma have been identified. Some of the most common are 1. Allergic asthma. This is the most easily recognized asthma phenotype, which often commences in childhood and is associated with a past and or family history of allergic disease such as eczema, allergic rhinitis, or food or drug allergy. Examination of the induced sputum of these patients before treatment often reveals eosinophilic airway inflammation. Patients with this asthma phenotype usually respond well to ICS treatment. Second, non-allergic asthma. Some patients have asthma that is not associated with allergy. The cellular profile of the sputum of these patients may be neutrophilic, eosinophilic, or contain only a few inflammatory cells, or polygranulocytic. Patients with non-allergic asthma often demonstrate a lesser short-term response to ICS. Cough variant asthma and cough predominant asthma. In some children and adults, cough may be the only symptoms of asthma, and evidence of variable airflow limitation may be absent apart from during bronchial provocation testing. Some patients subsequently also develop wheezing and bronchodilator responsiveness. ICS containing treatment is effective. Adult onset or late onset asthma. Some adults, particularly women, present with asthma for the first time in adult life. These patients tend to be non-allergic and often require higher doses of ICS or are relatively refractory to corticosteroid treatment. Occupational asthma or asthma due to exposures at work should be ruled out in patients presenting with adult onset asthma. Asthma with persistent airflow limitation. Some patients with long-standing asthma develop airflow limitation that is persistent or incompletely reversible. This is thought to be due to airway wall remodeling. Asthma with obesity. Some obese patients with asthma have prominent respiratory symptoms and a different pattern of airway inflammation. With little eosinophilic inflammation. There is little evidence about the natural history of asthma after diagnosis, but one longitudinal study showed that approximately 16% of adults with recently diagnosed asthma may experience clinical remission, no symptoms or asthma medication for at least 1 year within 5 years. Making the initial diagnosis. Making the diagnosis of asthma before treatment is started, as shown in box 1 and 2, is based on identifying both the characteristic pattern of respiratory symptoms such as wheezing, shortness of breath or dyspnea, chestiness or cough, and variable expiratory airflow limitation. The pattern of symptom is important as respiratory symptoms may be due to acute or chronic conditions other than asthma. If possible, the evidence supporting a diagnosis of asthma should be documented when the patient first presents, as the features that are characteristic of asthma may improve spontaneously or with treatment. As a result, it is often more difficult to confirm a diagnosis of asthma once the patient has been started on ICS-containing treatment, because this reduces variability of both symptoms and lung function. GINA recognizes that globally many health professionals lack access or ready access to spirometry, so advice has also been provided for using PEF in asthma diagnosis. Box 1-1 Diagnostic flowchart for adults, adolescents, and children 6 until 11 years in clinical practice. This flowchart is for patients presenting with chronic or recurrent respiratory symptoms in clinical practice. Patients with chronic or recurrent respiratory symptoms are symptoms typical of asthma. If it is yes, detailed history or examination. Do the history or examination support diagnosis of asthma? If yes, is patient already taking ICS treatment? If yes, See box 1-3 for diagnostic approach in patient already on ICS. But if the answer is no, does the patient have severe uncontrolled respiratory symptoms or sign? Is if yes, if other diagnoses are unlikely, treat empirically with ICS containing treatment. But if the answer is no, is spirometry or PEF available and visible? If yes, perform lung function tests as in box 1-2. For example, spirometry or PEF before and after bronchodilator. And then, is variable expiratory airflow limitation confirmed? Is yes, treat for asthma with ICS containing treatment. And for this, after treated empirically with ICS containing treatment, we should review the response in 1 until 3 months, including PF or spirometry if available, and have symptoms and lung function if available improve. If no, we should refer for higher level advice. For this step, repeat during symptoms or consider additional tests. If the first one are symptoms typically of asthma, and the answer is no, we should do the further history and test for alternative diagnosis. Is alternative diagnosis confirmed? If the answer is yes, treat for alternative diagnosis. Peak expiratory flow is less reliable than spirometry, but it is better than having no objective measurement of lung function. When measuring PEF, use the same meter each time as the value may vary by up to 20% between different meters and use only the highest of three readings. For other abbreviations, see page 11. For more information about diagnosis, see text and box. For books 1 and 2, criteria for initial diagnosis of asthma in adults, adolescents, and children 6 until 11 years. History of typical variable respiratory symptoms. Feature. Wheeze, shortness of breath, chest tightness, and or cough. Descriptors may vary between cultures and by age. Symptoms or features that support diagnosis of asthma. Symptoms occur variably over time and vary in intensity. Symptoms are often worse at night or in waking. Symptoms are often triggered by exercise, laughter, allergens, cold air. Symptoms often appear or worsen with viral infection. Confirmed variable expiratory airflow limitation. Feature. Excessive variability in expiratory lung function, one or more of the following. Positive bronchodilator responsiveness or reversibility, test with spirometry or PEF. Considerations. The definition and the criteria. The greater the variation or the more occasions success variation is seen, the more confident the diagnosis of asthma. If initially negative, test can be repeated during symptoms or in the early morning. If spirometry is not possible, PF may be used, but it is less reliable. Okay, for the reversibility test in adults, increase from baseline in FEV1 or FEG of more than equal to 12% and more than equal to 200 milliliter with greater confidence if the increase is more than equal to 15% and more than equal to 400 milliliter, or increase in PEF more than 20% if spirometry is not available. And for the children, increase from baseline in FEV1 of more than equal to 12% predicted, or in PEF of more than equal to 15%. Measure change 10 until 15 minutes after 200 until 400 microgram salbutamol or albuterol or equivalent. Compare with pre-bronchodilator readings. Positive test more likely if bronchodilator with help before test. SABA more than equal to 4 hours, negative bronchodilator 24 until 48 hours. Okay, and then the second feature, the excessive variability in twice daily PEF over 2 weeks. For adults, average daily diurnal PEF variability more than 10%, and children more than 13%. Increase in lung function after 4 weeks of treatment. In adult, increase from baseline in FEV1 by more than equal to 12% and more than equal to 200 milliliter RPF by more than equal to 20% after 4 weeks of daily ICS containing treatment. And for children, the increase in FEV1 of more than equal to 12% predicted or in PF of more than equal to 15%. Positive bronchial challenge test in adults fall from baseline in FEV1 of more than equal to 20% with standard doses of methacholine or more than equal to 15% with standardized hyperventilation, hypertonic saline or mental challenge are more than 10% and more than 200 milliliter with standardized exercise challenge. And in children, fall from baseline in FEV1 of more than 12% predicted or fall in PEF more than 15% with standardized exercise challenge. If FEV1 decreases during a challenge test, check that FEV1 per FVC ratio has also decreased, since incomplete inhalation due to inducible laryngeal obstruction or poor effort can result in a false reduction in FEV1. Excessive variation in lung function between visits. Good specificity but poor sensitivity. In adults, variation in FEV1 of more than equal to 12% and more than equal to 200 milliliter or in PEF of more than equal to 20% between visits. In children, variation in FEV1 of more than equal to 12% or more than equal to 15% in PEF between visits. Okay. Pattern of respiratory symptoms that are characteristic of asthma. The following features are typical of asthma and if present increase the probability that the patient has asthma. Respiratory symptom of wheeze, shortness of breath, cough, and or chest tightness. Symptoms are often worse at night or in the early morning. Symptoms vary over time and in intensity. Symptoms are triggered by viral infection like colds, exercise, allergen exposure, change in weather, laughter, or irritants such as car exhaust fumes, smoke, or strong smells. The following feature decrease the probability that respiratory symptoms are due to asthma. Chronic production of sputum, shortness of breath associated with dizziness, lightheadedness, peripheral tingling or paresthesia, chest pain, exercise-induced dyspnea with noisy inspiration. Differential diagnosis. The differential diagnosis in a patient with suspected asthma varies with age. Any of these alternative diagnoses may also be found together with asthma. In age 6 until 11, if the symptom is sneezing, itching, blocked nose, and throat clearing, we should also think about the chronic upper airway cough syndrome. Sudden onset of symptoms, unilateral wheeze, we should think of inhaled foreign body that usually it will obstruct in the right bronchi. And recurring infection, productive cough, we should think about bronchiectasis because in bronchiectasis there is a daily sputum production and the daily sputum production can obstruct the airway, make the bacteria accumulate and cause the recurrent infection. If the symptom is recurrent infection, productive cough, and sinusitis, think about primary ciliary dyskinesia. If the symptom is cardiac murmur, think about congenital heart disease. Preterm delivery, symptoms tinge birth, think about bronchopulmonary dysplasia. Excessive cough and mucus production, gastrointestinal symptoms, think about cystic fibrosis. In age 12 until 39, if the symptom is sneezing, itching, blocked nose, and throat clearing, think about chronic upper airway cough syndrome. If the symptom is dyspnea, inspiratory wheezing, or stridor, think about inducible laryngeal obstruction. If the symptom is dizziness, paresthesia, and sighing, think about hyperventilation or dysfunctional breathing. If It is productive cough or recurrent infection. Think about bronchiectasis, excessive cough and mucus production. Think about cystic fibrosis. That usually in cystic fibrosis, it can also be found the bronchiectasis. Cardiac murmurs, think about congenital heart disease. Shortness of breath, family history of early emphysema. Think about alpha-1 antitrypsin deficiency. Sudden onset of symptom. Think about inhaled foreign body. In age 40 plus years, if the symptom is deep snow, inspiratory wheezing, stridor, think about inducible laryngeal obstruction. If the symptom is dizziness, paresthesia, and psyching, think about hyperventilation or dysfunctional breathing. If the symptom is cough, sputum, dyspnea, or exertion, smoking or noxious exposure, think about COPD. If the symptom is productive cough, recurrent infection, think about bronchiectasis. If the symptom is dyspnea with exertion, nocturnal symptoms or ankle edema, think about cardiac failure. If the symptom is treatment with angiotensin converting enzyme inhibitor, think about medication-related cough. If the symptom is dyspnea with exertion, non-productive cough, finger clapping, think about parenchymal lung disease. If the symptom is sudden onset of dyspnea and chest pain, think about pulmonary embolism. If the symptom is dyspnea and unresponsive to bronchodilators, think about central airway obstruction. And if the symptom is chronic cough, hemoptysis, dyspnea, and orthotic fever, night sweats, anorexia, weight loss in all age, think about tuberculosis. And if there is a prolonged paroxysm of coughing and sometimes stridor, think about pertussis. Why is it important to confirm the diagnosis of asthma? This is important to avoid unnecessary treatment or overtreatment and to avoid missing other important diagnoses. In adults with an asthma diagnosis in the last 5 years, one third could not be confirmed as having asthma after repeated testing over 12 months with stage withdrawal of ICS containing treatment. The diagnosis of asthma was less likely to be confirmed in patients who did not undergo lung function testing at the time of initial diagnosis. Some patients, 2%, had serious cardiorespiratory condition that had been misdiagnosed as asthma. It is important to confirm that the diagnosis of asthma in people with suggestive respiratory symptoms. A study in Canada found that patients with undiagnosed asthma had worse health-related quality of life and more unscheduled healthcare visits than those without asthma, and similar to those with diagnosed asthma. History and family history. Commencement of respiratory symptom in childhood, a history of allergic rhinitis or eczema, or a family history of asthma or allergy increases the probability that respiratory symptoms are due to asthma. However, these features are not specific for asthma and are not seen in all asthma phenotypes. Patients with allergic rhinitis or atopic dermatitis should be asked specifically about respiratory symptoms. Physical examination in people with asthma is often normal. The most frequent abnormality is expiratory wheezing or rhonchial auscultation, but this may be absent or only heard on forced expiration. Wheezing may also be absent during severe asthma exacerbation due to severely reduced airflow, so-called silent chest, but at such times, other physical signs of respiratory failure are usually present. Wheezing may also be heard with inducible laryngeal obstruction, COPD, respiratory infection, tracheomalacia, or inhaled foreign body, when wheezing may be unilateral. Crackles or capitation and inspiratory wheezing are not features of asthma. Examination of the nose may reveal signs of allergic rhinitis or nasal polyps. Lung function testing to document variable expiratory airflow limitation. Asthma is characterized by variable expiratory airflow limitation. Expiratory lung function varies over time and in magnitude to a greater extent than in healthy population. In asthma, lung function may vary over time between completely normal and severely obstructed in the same patient. Poorly controlled asthma is associated with greater variability in lung function than well-controlled asthma. Lung function is most reliably assessed by spirometry testing, with assessment of forced expiratory volume in 1 second and the ratio of FEV1 to forced vital capacity. Spirometry testing should be carried out by well-trained operators with well-maintained and regularly calibrated equipment, with an inline filter to protect against transmission of infection. However, globally, many clinicians do not have ready or any access to spirometry. In this context, assessment of PEF, although Less reliable is better than no objective measurement of lung function. If PF is used, the best for three measurements should be used each time, and the same method should be used for follow-up testing, as measurement may differ from method to method by up to 20%. A reduced FEV1 or PEF may be found with many other lung diseases or poor technique with inadequate inhalation. This may be due to lack of effort or to inducible laryngeal obstruction. Reduced FEV1 per FEG compared with baseline or compared with the lower limit of normal indicates expiratory airflow limitation. Many spirometers now include age-specific predicted values for lower limit of normal in their software. In clinical practice, once an obstructive defect has been confirmed, variation in airflow limitation is generally assessed from variation in FEV1 or PEF. Variability refers to improvement and or deterioration in symptoms and lung function. Excessive variability may be identified over the course of one day or diurnal variability from day to day, from visit to visit, or seasonally, or from a responsiveness test. Responsiveness, previously called reversibility, generally refers to rapid improvement in FEV1 or PEF measured within minutes after inhalation of a rapid-acting bronchodilator, such as 200-400 microkilogram salbutamol, or more sustained improvement over days or weeks after the introduction of ICS treatment. In a patient with atypical or suggestive respiratory symptoms, obtaining evidence of excessive variability in expiratory lung function is an essential component of the diagnosis of asthma. Some specific examples are an increase in lung function 10 until 15 minutes after administration of a bronchodilator, or after a trial of ICS containing treatment, lung function may improve gradually, so it should be assessed after at least 4 weeks. A decrease in lung function after exercise or spontaneous or standardized or during a bronchial provocation test. Variation in lung function beyond the normal range when it is repeated over time, either on separated visits or on twice daily home monitoring over at least 1 until 2 weeks. Specific criteria for demonstrating excessive variability in expiratory lung function are listed in box 1-2. A decrease in FEV1 or BF during expiratory infection, while commonly seen in asthma, does not necessarily indicate that a person has asthma, as it may also be seen in otherwise healthy individuals or people with COPD. How much variation in expiratory airflow is consistent with asthma? Bronchodilator responsiveness. There is overlap in bronchodilator responsiveness and other measures of variation between health and disease. In a patient with respiratory symptoms, the greater the variations in their lung function or the more time excess variation is seen, the more likely the diagnosis is to be asthma. Generally, in adults with respiratory symptoms typical of asthma, an increase or decrease in FEV1 of more than equals to 12% and more than equal to 200 milliliter from baseline, or if spirometry is not available, a change in BF of at least 20% is accepted as being consistent with asthma. A technical standard committee recommended changing the criterion for a positive bronchodilator responsiveness test from an increase from baseline in FEV1 or FEVG of more than equal to 12% and more than 200 milliliter as at present to an increase from baseline of more than 10% of the patient's predicted value. This recommendation was based on data for survival, and the Technical Standard Committee avoided making any recommendation about the use of this criterion for diagnostic decision in clinical practice. Diurnal PF variability is calculated from twice daily readings as the daily amplitude percent mean. Days highest minus days lowest divided by mean of days highest and lowest multiple by multiply by 100. Then the average of each day's value is calculated over 1 until 2 weeks. The upper 95% confidence limit of diurnal variability, amplitude percent mean from twice daily readings is 9% in healthy adults and 12.3% in healthy children. So, in general, diurnal variability more than 10% of adults and more than 13% for children is regarded as excessive. If FEV1 is within the predicted normal range when the patient is experiencing symptoms, this reduces their probability that the symptoms are due to asthma. However, patients whose baseline FEV1 is more than 80% predicted can have a clinically important increase in lung function with bronchodilator or ICS containing treatment. Predicted normal ranges, especially for PF, have limitations, so the patient's sound-based reading or personal best is recommended as their normal value. Steps for confirming the diagnosis of asthma in a patient already taking ICS containing treatment. Current status and steps to confirm the diagnosis of asthma. Variable respiratory symptoms and variable airflow limitation. Diagnosis of asthma is confirmed. Assess the level of asthma control and review ICS containing treatment. Variable respiratory symptoms but no variable airflow limitation. Consider repeating spirometry or PEF after withholding bronchodilator for hours for SABA, 24 until 48 hours for long-acting bronchodilator or during symptoms. Check between visit variability of FEV1 and bronchodilator responsiveness. If still normal, consider other diagnosis. If FEV1 or PEF is more than 70% predicted, consider stepping down ICS containing treatment and reassess in 2 until 4 weeks. Then consider bronchial provocation tests or repeating bronchodilator responsiveness tests. If FEV1 is less than 70% predicted, consider starting or stepping up maintenance ICS containing treatment for 3 months. Then reassess symptoms and lung function. If no response, resume previous ICS dose and refer patient for diagnosis and investigation. Few respiratory symptoms, normal lung function, and no variable airflow limitation. Consider repeating BD responsiveness test again after withholding bronchodilator as above or during symptoms. If normal, consider investigation for alternative diagnosis. Consider stepping down ICS containing treatment. If symptoms emerge and lung function falls, asthma is confirmed. Step up ICS containing treatment to previous lowest effective dose. With no change in symptom or lung function at lowest controller step, consider choosing maintenance ICS containing treatment or switching to as needed only ICS formoterol and monitor patient closely for at least 12 months. Persistent shortness of breath and persistent airflow limitation. Consider stepping up ICS containing treatment for 3 months, then reassess symptoms and lung function. If no response, resume previous ICS dose and refer patient for further investigation and management or manage as for patients with features of both asthma and COPD. When can variable expiratory airflow limitation be documented? If possible, evidence of variable expiratory airflow limitation should be documented before treatment is started. This is because variability usually decreases with ICS treatment as lung function improves. In addition, any increase in lung function after initiating ICS containing treatment can help to confirm the diagnosis of asthma. Bronchodilator responsiveness may not be present between symptoms during viral infection or if the patient has used a beta 2 agonists within the previous few hours, and in some patients with asthma, airflow limitation may become persistent or irreversible over time. If neither spirometry nor PF is available, or variable expiratory airflow limitation is not documented, a decision about whether to investigate further or start ICS containing treatment immediately depends on clinical urgency and access to other tests. Other tests that may be used in diagnosis of asthma. Bronchial provocation test. One option for documenting variable expiratory airflow limitation is to refer the patient for bronchial provocation testing to assess airway hyperresponsiveness. Challenge against include inhaled methacholine, histamine, exercise, acoustic, voluntary hyperventilation, or hand mannitol. These tests are moderately sensitive for a diagnosis of asthma but have limited specificity. For example, airway hyperresponsiveness to inhaled methacholine has been described in patients with allergic rhinitis, cystic fibrosis, bronchopulmonary dysplasia, and COPD. This means that a negative test in a patient not taking ICS can help to exclude asthma, but a positive test does not always mean that a patient has asthma. The pattern of symptoms and other clinical features must also be considered. Allergy test. The presence of atopy increases the probability that a patient with respiratory symptoms has allergic asthma, but this is not specific for asthma nor is it present in all asthma phenotype. Atopic status can be identified by skin prick testing or by measuring the level of specific immunoglobulin A in serum. Skin prick testing with common environmental allergen is simple and rapid to perform, and when performed by an experienced tester with standard extract, is inexpensive and has a sensitivity. Measurement of IgE is no more reliable than skin prick test and is more expensive, but may be preferred for uncooperative patients, those with widespread skin disease, or if the history suggests a risk of anaphylaxis. The presence of a positive skin test or positive S IgE, however, does not mean that allergen is causing symptoms. The relevance of allergen exposure and its relation to symptoms must be confirmed by the patient's history. Imaging. Imaging studies are not routinely used in the diagnosis of asthma, but may be useful to investigate the possibility of comorbid condition on alternative diagnosis in adults with difficult to treat asthma. Imaging may also be used to identify congenital abnormalities in infants with asthma-like symptoms and alternative diagnosis in children with difficult to treat asthma. High-resolution computed tomography of the lungs can identify conditions such as bronchiectasis, emphysema, lung nodules, airway wall thickening, and lung distension, and may assess airway distensibility. The presence of radiographically detected emphysema is considered when differentiating asthma from COPD, but there is no accepted threshold and this condition can coexist. Moreover, eye trapping, which may be present in asthma and is also a feature of aging, can be difficult to distinguish from emphysema. Chest imaging is not currently recommended to predict treatment outcomes or lung function decline or to assess treatment response. CT of the sinuses can identify changes such as stick of chronic rhinosinusitis with or without nasal polyp, which is in patients with severe asthma may help with choice of biology therapy. Exhaled nitric oxide. The fractional concentration of exhaled nitric oxide is modestly associated with the level of sputum and blood eosinophils, but this association is lost in obesity. Pheno has not been established as useful for ruling in or ruling out a diagnosis of asthma because while pheno is higher in asthma that is characterized by type 2 airway inflammation with elevated interleukin 4 and EL13, it is also elevated in non-asthma conditions like eosinophilic bronchitis, atopy, allergic rhinitis, eczema, and is not elevated in some asthma phenotypes like neutrophilic asthma or asthma with obesity. Pheno is also lower in smoker and during bronchoconstriction, and the early phases of allergic response, it may be increased or decreased during viral respiratory infection. For information on the role of pheno in asthma treatment, see section 4. Okay, that's all for chapter 1. We can continue the reading in the next video. Thank you.